Thank you, Dr. Nasser, for the kind invitation. Our case today, about 45 years male, diabetic hypertensive, heavy smoker, presented with right big toe, non-healing wound with severe wrist pain. Duplex show monophasic flow of anterior and posterior tibial with chronic total occlusion of superficial femoral artery and common femoral artery. CT angio reveals that external iliac and common femoral artery and superficial femoral artery chronic total occlusion. What is the plan for management? There are three modalities of treatment: either surgery, iliofemoral popliteal bypass, or endovascular trial of balloon angioplasty of the superficial femoral artery, either external iliac artery stent or versus balloon angioplasty, or hybrid procedures, balloon and stenting of external iliac artery with femoral popliteal bypass. Our plan to do hybrid procedures, balloon and stenting of external iliac artery with femoral popliteal bypass. From the contralateral approach, sheath, 8 French sheath was inserted retrograde in the left common femoral artery, and the diagnostic angiogram shows that there is external iliac and the common femoral artery and superficial femoral artery chronic total occlusion. This external iliac artery is chronic total occlusion, and here the external iliac and common femoral artery occlusion. We try to passage the wires through the external passes the wires through the common femoral artery and the external iliac artery, and this is angiogram after the passage of the wire. We try balloon angioplasty of external iliac artery and the profunda femoris artery, and the angiogram shows patent external iliac artery and the profunda femoris artery. Another trial to do to the superficial femoral artery and try to balloon angioplasty of superficial femoral and the tight lesions were present inflated by the balloon in the superficial femoral artery. Angiogram show patent both common femoral and superficial femoral and the profunda femoris artery. Good distal runoff from the popliteal and the infrainguinal popliteal and tibial vessels and the arch of the foot. External iliac artery balloon angioplasty by balloon 6 millimeter. Again, we found after twice inflation of the balloon or the dilatation of the external iliac artery, we found still tight stenosis in the mouth of the external iliac artery. We decide to do self-expandable balloon, self-expandable stent to external iliac artery. Stent dilatations again. This is the surprise. Unfortunately, chronic total occlusion and thrombosis of the stent and the external iliac and the common femoral and the superficial femoral artery and profunda. We're trying using 6 French guiding catheter for aspiration of the thrombus several times, and aspiration of the thrombus from the stent and from the common femoral artery, and do angiogram show residual thrombosis of both common femoral and superficial femoral artery and profunda. Final angiogram, we found that external iliac artery thrombosis and common femoral artery thrombosis and the profunda thrombosis. And the stent is totally occluded. And the patient complaining from signs of acute limb ischemia, severe agonizing pain. We go to the operating theater and do surgery for him. Femoral artery thrombectomy groin exploration and of common femoral artery and the lower part of the external iliac and profunda and superficial femoral artery. Longitudinal arteriotomy was done. Thrombin arterectomy of common femoral and superficial femoral artery. Explantation of external iliac artery stent. Wash by heparinized saline as usual. Explant the stent and the atherosclerotic plugs. And we do infragenicular thrombectomy with closure of the venous patch, but several times thrombosis intraoperative. We decide to do intraoperative laboratory investigation, CBC. We found that the platelet count intraoperative about 32,000, while before the surgery is 266. 2 days after the operation day, it is 147, and on the charge 232. It is acute head syndrome. The patient by flashback, we found that the patient is on prophylaxis low molecular weight heparin, and intraoperative during the procedure, the patient received 6 ampoules of cal heparin. And as regarded the features, acute intraoperative heparin-induced thrombocytopenia and thrombosis during coronary artery bypass grafting, 2 cases reported providing evidence of the role of the preoperative low molecular weight heparin in triggering the sensitization. The development of acute intraoperative hit secondary to high dose of unfractionated heparin administration for coronary revascularization, in which the unexpected presence of platelet activating anti-platelet factor 4 and heparin antibodies at the surgery was explained by preoperative administration of 1 week course of low molecular weight heparin without any preoperative evidence of heparin-induced thrombosis. Completion angiography shows that patent external iliac and superficial femoral artery and popliteal artery and infrajugular segment and patent posterior tibial artery. After 2 months follow-up, duplex, patent common femoral artery and superficial femoral artery and triphasic wave of posterior tibial artery. Unfortunately, chronic total occlusion of anterior tibial artery. Our conclusion that endovascular intervention is worse to be the first trial for task D lesions, short recovery period, less discomfort, and under local and regional anesthesia. Common things are common, but you think about acute head syndrome during surgical procedures. That is no technical, as there is no technical issues and adequate anticoagulated patients. Hybrid procedure is actually hybrid procedure is actually safer and more effective than any standard procedures. Be aware of patient medications before any vascular intervention.